Welcome to today's web chat about pelvic floor disorders. Thank you for joining us. My name is Ali Novara, and I have the privilege of working with the Women's Health Program at Von Voigtlander Women's Hospital. I will be your host for today's chat. 1 out of 4 women over the age of 20 suffer with some form of pelvic floor disorder, whether it be pelvic organ prolapse, urinary incontinence, or bowel leakage. But it's not something that gets talked about enough. That's why we're here today. You don't have to live with incontinence or prolapse. Our goal today is to give you the information and confidence you need to take action and regain the freedom you deserve. Of course, while making the decision to get treatment is the first step, today we will also provide you with some tips on how to choose a provider and a program that's right for you. We'll introduce our panelists in a moment, but first a few housekeeping items. You can submit questions at any time, even now, for our panelists to answer during the Q&A portion of today's chat. Questions can be submitted by commenting on this video, but please note that your name or profile name will be visible to others participating. If you prefer a more anonymous option, you can send a private message to us via Facebook or email at ask-mishmed@med.umich.edu. If you can't stay for the whole chat or want to share the recording with a friend, a video of the chat in its entirety will be available on our Facebook page and posted to the Michigan Medicine YouTube channel soon after. I'd like to introduce you to our panelists now. Each of our panelists are board-certified female pelvic medicine and reconstructive surgery physicians. Dr. Megan Schimpf is a gynecologist with our urogynecology program, seeing patients with pelvic floor disorders at the Von Voigtlander Women's Clinic in Ann Arbor, as well as at our clinic in Northville. Dr. Dan Morgan is also a gynecologist in our urogynecology program, seeing patients at Von Voigtlander Women's Clinic in Ann Arbor and at St. Joseph Health Hospital in Ann Arbor. And Dr. Pamela Fairchild sees patients at our urogynecology program clinics in Ann Arbor, both at Von Voigtlander Women's Clinic and our new West Ann Arbor Parkland Plaza Clinic. She also sees patients at the Mid-Michigan Women's Health Center in Midland. Additional faculty members on the team include Dr. John Delancey, Dr. Dee Fenner, and Dr. Carolyn Swenson. Thank you again for joining us. Now, let's jump right in. Why don't we start with a general overview of what pelvic floor disorders are?
So pelvic floor disorders can take many different forms, and we know that these aren't necessarily conditions that are easy to talk about. A lot of people suffer in silence, and so that's one thing that we're here today. We'd love to take your questions about what might be a pelvic floor disorder if you're not sure. We'll start with one type of pelvic floor disorders is urinary incontinence, or leakage of urine when you don't want it to be coming out. That can happen when you laugh, cough, and sneeze, which is called stress urinary incontinence. We also see that sometimes when folks are exercising, jumping on a trampoline, or maybe even yelling at your kids. Sometimes we have different problems with urinary incontinence when women are trying to get to the bathroom but can't quite make it in time, where you get that sense that you gotta go, but you can't make it to the toilet before the urine stream starts coming out. That's called urgency incontinence, or sometimes called overactive bladder. There are other forms of urinary incontinence as well, but those are the most common types, and actually the most common thing is to have a little bit of both of those conditions that can frustrate you throughout the day. Another form of pelvic floor disorders is called pelvic organ prolapse. That's where one or more of the organs in the pelvis can start dropping through, usually through the vaginal opening. That can mean the bladder is dropping, the uterus is dropping, the vaginal walls are dropping, or maybe the bowels are bulging upward into the vagina from below. Prolapse can cause a lot of different symptoms, and sometimes they're hard to precisely identify. We know that patients often have a sense of a bulge coming through the vaginal opening, sometimes small, sometimes large. Sometimes patients get this sense of pressure or something being there that's not supposed to be there. And sometimes there's even bleeding or soreness from the rubbing of the tissue, maybe on your underwear. There are lots of other symptoms, but those are the most common ones that we see. Moving along on the list of pelvic floor disorders, we know that some patients have what's called accidental bowel leakage, or stool or bowel material that comes out when you don't want it to. That can even include gas that comes out when you're not ready for it. This can be a very isolating problem and can be difficult to treat, but we have a long list of options through our Michigan Bowel Control Program that provide women a lot of relief from those symptoms. Other additional pelvic floor disorders can include pain, perhaps in the muscles of the pelvic floor. That can cause a sense of pressure. It can cause difficulty with intercourse. Sometimes that happens for no clear reason. Sometimes it can happen after other surgery or after childbirth. We unfortunately have seen a lot of women recently with pain in the pelvis after having surgery for one of these problems, perhaps using mesh material. We can talk about that more a little bit later. There's also a pain condition that affects the bladder called interstitial cystitis or painful bladder syndrome. That can cause folks to have to get up out of the bed at night, often to go to the bathroom, frequently being in the bathroom during the daytime, and just always having a sense of burning and pressure in the pelvis. There's a lot of different treatments for all of these collective problems. Not everybody needs surgery for one of these problems. We see some patients that want surgery, and that's great. We're here to do that. But not everybody has to have surgery. We have great solutions for some of these problems that don't involve surgery. And so one of our goals here at Michigan Medicine is to tailor your treatment to your desires and your lifestyle and your medical history. If you want to have surgery, we can do that for you. If you don't want surgery, maybe you've had a lot of surgeries or you've got too much going on in your life right now, there's pelvic floor physical therapy, there are medications, there are little devices that can be put into the vagina to help with a lot of these problems. Sometimes it's just about changing your diet, changing what you drink, changing what you eat. That can cause some relief from most of these conditions. So that means that we can offer you a range of options for these problems. And they're definitely not something you just have to live with just because you're getting old or just because you had a baby. We're here to make those things totally not true anymore.
Great, thank you for that overview. We'll open up the floor for questions now. I'd like to remind our audience that you can submit questions by commenting on this video directly, by direct messaging us on Facebook, or by emailing us at ask-mishmed@med.umich.edu. We will not use your name when we read off your question, but do know that if you comment directly on this video, your name or profile name will be visible to other participants. So let's get started. The first question is, why is my leakage worse at night?
I can start with that. There are many times that, as we're talking, this is often something that can be addressed with understanding what's going on with you in general in terms of other medical problems, as well as what your habits are around eating dinner and drinking fluids at night. So one of the most common things that we see is that people will continue to have beverages or fluid all the way up closer to bedtime. And so often that can make things a little bit worse, and that if you're perhaps not able to drink what you want to drink during the day in terms of fluids, and you make up for that in the early evening, that's going to make some of your symptoms worse at night. So it tends to be something that's fairly common sense, but it sometimes we just don't recognize it, and over the years, sometimes our ability to tolerate that changes. So sometimes you'll notice a change that suddenly you have difficulty tolerating that. There are also some reasons related to other medical problems. So many times we'll store some fluid in tissues that you'll see either in your legs or in your hands. And at night, when you're recumbent and lying down, some of those that water will get reabsorbed, and then so that's often another reason that people will end up making more urine at night. So that's I think a couple things. I don't know if you guys have other thoughts about that. No.
I think specifically too for the elderly, there are hormonal changes that impact when your urine is made, and so some older women will find that all of a sudden they're making a lot of urine at night and during the day instead of making most of their urine during the day. That's called nocturia or polyuria, and is common as women age.
Great, thank you. The next question is, how often do you see a genetic predisposition for pelvic floor disorders in family generationally?
I think frequently we see patients who say, I knew I had this because my mother had it, or I remember my grandmother using a device to help with this problem. And it is definitely associated in families, but there's not a strong genetic component that we're really aware of now. There's not genetic testing to say, hey, I'm going to get incontinence or prolapse later in life because of my family history. And certainly you see women whose mothers have prolapse or incontinence and they don't have such issues. And there are many women who have prolapse or incontinence and they're the first person in their family, or at least the first person in their family that talked about it. Because oftentimes there's a generational issue with these conditions being kind of taboo to talk about with your children or your family members.
We know that one of the biggest risk factors for a lot of pelvic floor disorders is having a baby. And so that tends to run in families. If you have babies, you tend to be in a family. So that is one way it runs in families. And there's some connection, but there's so many other things that play into these conditions that it's not purely a genetic condition.
Great, thank you. We've got some great questions coming in. The next one is, why do sling surgeries tend to fail in older female patients?
Can start off on, so just a quick thing. So what is meant by a sling surgery? And in general, what we're referring, when you hear somebody refer to a sling, it can be confused sometimes between an operation for incontinence or for prolapse. And that goes for the word bladder suspension as well. So thinking about what does a sling mean specifically, we really think of it as being something that addresses stress incontinence, which Dr. Schimpf had mentioned is going to be a condition of leaking that happens when you do something physically active that causes an increase in pressure and then leads to, in your abdomen, and leads to leakage. And a sling surgery is really aimed at trying to prevent that type of incontinence. So it's helpful to be specific about what we're talking about when we say sling. But so things can not necessarily relieve all somebody's symptoms for many different reasons. And we certainly see that sometimes patients will say the surgery didn't work because I'm having leakage still, or because I have some symptoms of a bulge once again. So it's helpful really as and I think this comes up most often when people are talking to other friends or family and they're trying to figure out what worked and what didn't. And so it's helpful to understand that things can maybe not work for many different reasons, and that sometimes what is meant by a sling can really change a lot between individuals. So just to be helpful, and I think that's when it's most helpful to really get a chance to talk to one of us and to try to sort out what was done in the surgery and what your symptom is, so that we can really tease that out a little bit better.
I think one of the key things too is that we have effective treatments for women of all ages. And like Dr. Schimpf had said earlier, that's not necessarily surgery. There's a lot of different ways we can approach things, and depending on what your symptoms are, there may be a sling that's going to fix it, but there may be other things that you need to think about. And you shouldn't think, I'm older and I'm not going to have an effective treatment because of my age, because age is just a number, as we know, and we have treatments for everybody.
Things change sometimes throughout your life. So maybe you had a sling surgery for incontinence, for that stress urinary incontinence at one point in life, and then later on you develop some of those urgency and overactive bladder symptoms. Unfortunately, the surgery doesn't fix those. And so you might think the surgery is failing, but really the whole picture has changed. And so I agree with Dr. Morgan that that's a good time to come in, take a whole comprehensive look at the picture, and see what else we can do to fix those new problems.
Is there research to support better success with sling repair if PT is done for levator, excuse me, training prior to it? That was a rough question. Hold on one moment. Let's try that again.
I think what they're trying to ask is if there's a role for physical therapy when you're also having a surgery for incontinence or prolapse. And the issue of prolapse has been specifically looked at in the type of repairs we most frequently do here at the University of Michigan, which are called native tissue repairs. And there was an excellent trial that was done with one of our largest research groups in pelvic floor disorders that showed that there really isn't much of a difference when you add physical therapy onto surgery. It doesn't seem to make it more effective in the short term, or they didn't do a very long-term study, but within about 5 years, there wasn't really a difference between those women. I think the physical therapy has a role as an individual treatment, and I think there's also other benefits of physical therapy beyond did it fix the problem, meaning feeling better about your pelvic floor, having more knowledge about how your pelvic floor works. And physical therapy can be a very beneficial intervention for really all pelvic floor disorders. And so even if you're not doing it specifically because, oh, I want to make my surgery better, doing it if you're interested is something I strongly recommend. I think most of us prescribe a lot of pelvic floor physical therapy.
Just to note, in past years when we've done this, we've often had one of our physical therapy colleagues available here. Jen Schifford has somebody who is we've worked with over the years, and she's trained a large group of women at U of M who specialize in pelvic floor therapy. So there's a lot of expertise at Michigan Medicine with respect to physical therapy, and we've all, I think, been really fortunate to work with them, and so certainly it's a good thing to consider.
Okay, moving on to the next question. I have been utilizing a pessary for almost 5 years. Is this a long-term solution?
I think a pessary is a great long-term solution if it's working for you and you want it to be. So I have some patients who find a pessary is life-changing. We can often fit them in the course of your initial visit with us. And it's a very low-risk, simple way of treating incontinence of either mostly the urinary kind. There are some new pessaries that address bowel problems. And it's also a great treatment for prolapse. Some people find that, again, life-changing and use them forever. So there's no time limit on how long you can use a pessary. I have other patients who the pessaries start to cause some sort of problem, like maybe it rubs in the vagina and causes kind of like a sore to form. Maybe it doesn't fit so well anymore. Again, time goes on, things change. And maybe your life circumstances change and it's just not working for you anymore. And in that event, it's time to talk about a new problem or a new solution to the problem. But if it's working for you and you're happy with it, keep going.
Great, thank you. I was diagnosed with the trifecta prolapse of the bladder, uterine, and rectocele. Is it possible to deal with only one prolapse, or do all three need to be addressed?
You know, I think we often see women that have what you're describing is called multi-compartmental prolapse. If we think about the vagina having different places, kind of the front, which we call the bladder side, the back, which is the rectocele or the rectum side, and the top, which is the apex. Most women that have prolapse have some degree of descent of all of those compartments. If we choose a surgical treatment to address them, one of the concerns is that if you don't address everything that you're seeing, you're going to potentially worsen or unmask worse prolapse in the compartment you've neglected. That's something that we've looked at with MRI studies here at the University of Michigan. There is some concern that we want to make sure we're addressing every compartment to prevent it from, I fix your cystocele, which is the front of the vagina or the bladder, but then you come back in 6 months and the cystocele repair still looks great, but then you've got a rectocele, which is the back wall. So I think addressing them all makes sense if you're going to have surgery. It's also sometimes difficult to tell what the symptoms are coming from, right? So you may not really be truly aware of which component of the prolapse is causing your symptoms.
And I think it's also maybe important to understand that might make the surgery a little bit longer, but your recovery is probably not going to be a whole lot different, like Dr. Fairchild is saying, if we address one compartment versus addressing the 2 or 3 compartments that you need. So I don't think I think it's worth doing all at one time, because if you're going to invest the time in having surgery and recovering, why not go for everything at once?
Thank you. How would I know if I have stress incontinence versus a different kind?
Maybe just take one step back.
Sure.
That other question. I was thinking, I think all of us are trying to be really careful about what you decide to do at the time of surgery. There are many times when you do have both a cystocele and rectocele and uterine prolapse, But I think one of the things that we all really have worked at is that if it isn't broken, don't fix it.
Right.
And so it's not necessarily that you have to have everything done no matter what. It's really just a matter of like if there's prolapse in that area or there's something that really is going to benefit you from that repair, then it makes sense to do. But I think all of us try to really be careful about just addressing what needs to be addressed.
Thank you. So we'll circle back to that question. How would I know if I have stress incontinence versus a different kind?
I can take that. So stress urinary incontinence tends to happen with some kind of pressure or stress on your bladder. So coughing, laughing, sneezing, running, jumping, some kind of exertion that you're doing, and you notice the leakage right as you're doing that exertion. So even, just immediately, not even a few seconds later. The other forms of incontinence tend to happen more randomly throughout the day, more associated with the urge to go to the bathroom, and not so much with one of those exertional activities. There is some testing that we can do in the office. There's a range of tests from pretty simple, straightforward things up to more formal, machine-based tests that give us some numbers and some more sophisticated information. But oftentimes just talking about it can help us understand what's going on.
There are sometimes, you go. Yeah.
I think too, one of the important things to remember is that you could talk to your provider about it. So tell us what your symptoms are. Primary care providers are also good at kind of talking to you, starting at the base level with physical therapy or lifestyle changes you can make and making referrals when appropriate. Don't try to figure it out on your own. We're here to help you.
Yeah.
Thinking sometimes one of those symptoms that doesn't fit so well into one of the the names that we give it, but just is a feeling of just being wet all the time, and we spend often we can help understand if there's something going on, that sometimes there's a vaginitis or a vaginal infection that can present a lot like incontinence, but isn't necessarily incontinence. You can't tie it to an urgency sensation or some type of physical activity. So that's something that we can often help sort out as well with some fairly simple things that really are you'll be able to help us figure out with just a little bit of discussion. So.
That's a great point.
Yeah.
Is there a direct correlation between stress incontinence and recurring urinary tract infections?
I would say in general, no.
Yeah, I would agree.
But they are certainly things that we sometimes see at the same time, and so that's one of those things that really helps to understand several things about your exam and what we're finding, but in general, I think we can say no.
Yeah.
Yeah.
I think sometimes too, if there's a hygiene issue, and that's more typically we think about things like accidental bowel leakage or fecal incontinence, those can be associated with recurrent infections just because you have a hygiene issue around the urethra, which is where the urine is coming out, and potentially bacteria could get in to cause an infection. But typically stress urinary incontinence or even urgency incontinence is not really associated with infection.
Thank you. The next question that came in was, I had a grandmother who received a permanent catheter for her incontinence. Is that still one possible treatment? And how can I avoid that?
I can start on that. I think that's an answer for very extreme circumstances. And so maybe your grandmother had some sort of other health problem going on. But that is a very extreme and fairly unusual thing. That's certainly not on the list of things that we offer most people. So that's good news. Most people don't want a catheter permanently. So we can definitely do things better than that to help with the incontinence. I think there's lots of great things that you can do to try to avoid that. Dr. Fairchild was talking earlier about pelvic floor physical therapy. I've had so many patients find that to be a very valuable learning experience, first of all, just understanding their own body and their own anatomy better, and then they can get fantastic treatment success from that too. Our physical therapists would tell you that they've had patients who go through the course of treatment and they're able to run a marathon without leaking urine. So that's a pretty impressive statistic.
And I think there's certainly a desire to try to avoid indwelling catheters. I think one of the questions was about the risk for recurrent bladder infections. And so there really is, I think, across all areas of medicine, we really try to avoid that as an option. It is something that is rarely used in very difficult circumstances, and something that I think that would be something that we try to avoid just because of that recurrent bladder infection risk. I was thinking about one thing with that previous question about the recurrent stress incontinence and UTIs. One of the things that you'll notice, though, is certainly that is worthwhile is if you have the development of new incontinence symptoms, we will check a urinalysis because a bladder infection can cause incontinence. So it's that's one of those things that is very worthwhile to check. But recurrent urinary tract infections and chronic stress incontinence don't necessarily have a relationship. Yeah.
Okay, thank you. Okay, next question. I'm not sure my symptoms are really bad enough for surgery. It's really just when I cough or go running. Can special exercises help with this?
I think this goes back to physical therapy. As part of our assessment when we see patients in clinic, we assess the pelvic floor muscle strength and the ability to use your muscles to squeeze the pelvic floor. And for women that are already able to do that, just working on exercises at home can be helpful and effective, and having like a sheet that describes how to do that is something we'll often give people. Many women can't activate those muscles without some training, and that's where I think physical therapy has an important role. So we'll send those patients to one of our excellent physical therapists here at the University of Michigan, and they get that training. And like Dr. Schimpf said earlier, marathon runners can run marathons again. I've really seen pretty miraculous results just from learning how to activate your pelvic floor muscles and use them to control your bladder. And that goes for stress urinary incontinence as well as urgency incontinence. It's not just the former there. I think it's important to get an assessment to know that you're doing the exercises correctly, because sometimes we think we're squeezing the right muscles, but maybe we aren't. So just having a visit with your primary or your gynecologic care provider to say, hey, am I squeezing these right? How's my pelvic floor strength is a good thing to know.
Great, thank you. Can having sex make my incontinence worse?
I'll start on this one. So the answer to that is not really, in that having sex doesn't create incontinence or isn't going to cause trauma or things like that makes incontinence worse. That being said, there are certainly people who leak more with intercourse. So if you already have leakage, you can certainly notice that during intercourse. And I know that there are certainly patients I've spoken to about this who find this a very distressing symptom, very embarrassing, particularly in a new relationship. So sometimes that can be the stress type incontinence where the pressure of intercourse can cause that leakage. Sometimes it can also be that that the intercourse provokes a bladder spasm and you're leaking from that problem as well. So sex doesn't really cause incontinence, but it can bring out the symptoms that you're already having, all of which we can help you get rid of.
Thank you. Does untreated prolapse increase bladder or rectal cancer?
We can fortunately say no. That's a good news. Nice short one.
I think that's a good point, though. You do have patients that come in and are noticing a vaginal bulge, what we would consider prolapse, and one of their concerns is, do I have this bulge because I have cancer? Is this mass something I need to worry about? And most frequently the answer is no. And so we can take that worry off the table, which is nice.
Yeah. I think the thing that we all, would say though is if you notice that you are having bleeding of some sort, that certainly is something that doesn't mean that you have cancer, but it just raises the concern that that's a possibility and is something that's worth investigating. Sometimes a prolapse can rub and cause some bleeding, and that's not cancer. But it's more what we're worried about is looking to see is there a possibility of some kind of growth inside the uterus or in one of the other, the bladder or the rectum. And so that's something we'd search out and make sure that was okay. But
Thank you. Moving right along. My mom says she has an overactive bladder. Is that actually a form of incontinence? And is it hereditary?
I think overactive bladder encompasses a range of what we call lower urinary tract symptoms or bladder symptoms that include urgency incontinence, where you're leaking urine before you're able to make it to a toilet, but also things like urinary urgency without incontinence and urinary frequency, where you feel like you have to be in the bathroom all the time. And you're getting up at night to go to the bathroom. So those are all kind of under the realm of overactive bladder. Overactive bladder is more common as women age and after menopause. And there may be some form of hereditary there. It may run in families a little bit, but there's, like we spoke about earlier, there's not a strong genetic factor. So because your mother has overactive bladder, it doesn't mean that her children will necessarily have it. And there's certainly a lot of lifestyle factors that go into overactive bladder, smoking being one of them. That's very important. We all know that smoking isn't a healthy life choice for a lot of reasons, but for your bladder as well, it takes a toll. And like we were talking about earlier, what you choose to drink when you're drinking it makes a big difference as well.
Thank you. The next question. When I finish urinating, sometimes I feel like there's a little bit more left in my bladder. Is that normal? And can pelvic floor exercises help with that?
Maybe just before taking, I was wondering, like, Dr. Schimpf has done a lot of research on bladder irritants. Might be worthwhile just, saying something about,
jump
that's
back
like,
to that last question
that's
for a second.
Okay.
So
Yeah.
we're in the middle of a research study here that follows up on a whole line of work that we've been doing, looking at the impact of various beverages on the bladder. So this might be hereditary, I guess, depending on what mom teaches her kids to drink. But mostly I focus on talking to patients about reducing things like caffeine. So tea, coffee are the big offenders there. I think 1 or 2 cups a day is probably okay, but if you can eliminate everything, that's even better. And then artificial sweeteners, so diet beverages, even flavoring, maybe a water or a coffee with some sort of sweetener, that's going to definitely impact that. So things to avoid: Diet Coke, Crystal Light, again, tea, coffee, especially if you're using a sweetener on top of that. If you cut back or cut those out and completely, I think you're going to notice a huge impact on your bladder symptoms without any sort of medicine or pelvic floor therapy. In other words, a very low risk, cheap option for treating the problem. And you can try to replace those beverages with water, milk, or other non-irritating beverages. The other thing that most of us talk about all day long is the quantity of fluids that you're drinking. So we know that out there in the world is this, what's really a myth about the 8 glasses of water a day. Most of us get a lot of water from foods and from other sources. So even if you're drinking coffee, there's water in your coffee, right? So we don't have to totally count out that coffee as part of the water you need every day. So I see a lot of patients who are worried they're not getting enough fluid, but it's actually pretty easy to get enough liquid from just drinking something with a meal, eating foods, especially things like vegetables and fruits that contain a lot of water. And so feeling like you need to drink 8 glasses on top of that, maybe because you have an app on your phone or some sort of reminder system throughout the day. Most people do really fine with the just average drinking when you're thirsty. Feeling like you have to force fluids tends to land you in the bathroom more often than you need to be, and then you have to come see one of us. So you can work on that intervention just on your own at home by cutting back on the amount you drank and eliminating some of those irritating beverages.
I think one thing that Dr. Morgan had brought up earlier as well was if people have this goal of, I've got to get my 8 glasses in today, they may be really busy like many of us are during the day, and you realize, oh, it's 6 p.m. at night, I only had 2 glasses. So what I'm going to do is I'm going to drink a whole bunch of water right now so I get my 8 glasses today. And that will really challenge your bladder, and you will be up at night and suffer for it. And it's not necessary is the key thing.
Right.
There are a few medical conditions where you need to be drinking a lot of fluids, and typically you're aware if you have those.
You can also go by the color of your urine. So urine should have a color. It should have a pale yellow color. It shouldn't be dark orange. That probably means you're not getting enough liquid. But it does not need to be clear or look like water. Urine should have a color. Sometimes the amount of vitamins or the foods that you eat can affect the color or the smell of your urine. But generally speaking, kind of like a clear, light yellow urine is what we're going for.
Great, thank you.
We skipped a question.
Yep, we're going to go back to that question. So when I finish urinating, sometimes I feel like there's a little bit more left in my bladder. Is that normal, and can pelvic floor exercises help with that?
So a lot of people, when we go to the bathroom and urinate, don't completely empty the bladder. It's pretty frequent to leave some urine in that bladder. Your kidneys are also constantly making urine and refilling your bladder. So it's not unusual to feel a little bit more urine left over in the bladder, and that can be normal and not a problem at all. Any of us, I think, if we sat on the toilet for an extra 5 or 10 minutes, could probably produce a little bit more urine, and that's okay. That's not dangerous or anything like that. If you get the sense that there's a profound heaviness or pressure still in the bladder, might be a good idea to come see one of us or ask your regular doctor to check what's called a post-void residual. That means that your bladder isn't emptying completely if it's over a certain amount. And that can be connected to a couple of different problems like UTIs or even kidney damage in extreme cases. But that's pretty unusual. And so if it just feels like there's a little bit left over, not really a problem. Again, I feel like we can't say enough good things about pelvic floor physical therapy, but they can teach you some different maneuvers and techniques with your muscles to make sure you're emptying completely, but not straining too much, because that can cause problems with the muscles as well.
Thank you. In regards to the comments about PT assessment and treatment, does this mainly include mastering Kegel exercises, or are there more exercises, strengthening and stretching protocols included?
I think pelvic floor physical therapy, most people would be pretty amazed at what they do. They focus some on pelvic floor muscle strengthening, and they have different exercise regimens that they'll work people through. There's also some stretching they do. It's not all about necessarily working within the vagina. They do abdominal work, low back work. It's really all related to your pelvic floor. And that would include stretches. It can include sometimes for pain conditions or conditions where you're having muscle spasm, they'll do myofascial release, which is almost like massage for the muscles and getting those muscles to function more, improve their function basically. Pelvic floor physical therapy is a wide range of treatment options. Sometimes women have conditions where they don't need to be strengthening their pelvic floor muscles. They need to be helping those muscles relax to function better. And they do those things too. For women that are seeking physical therapy for conditions like stress urinary incontinence or urgency incontinence, it's not just about strengthening those muscles, it's about using those muscles at the right time and using those muscles to communicate with your bladder and your spinal cord and control your bladder function. It's pretty remarkable.
Great. Okay, next question. Should I try to avoid drinking water at certain times of the day to reduce my incontinence issues? We've touched on that a bit.
I think most people do recognize that they can control their symptoms to some degree by changing their fluid intake. So I think it's a perfectly reasonable way to go about things. And certainly it's something that can be helpful. Another thing that often goes along with that type of technique is doing something we call timed voiding. And so the idea of that is it helps with retraining, and also, as we've talked a little bit about overactive bladder, but one of the things that can happen with overactive bladder is if you get to a certain volume in your bladder, you'll have this sudden urgency to go. And once you feel that urgency, it's very difficult to control. So if you can combine a judicious fluid intake with timed voiding, often you can prevent yourself from getting to that bladder fullness where you suddenly have that very difficult to control bladder contraction. So I think as you're trying to think about how do you plan these things, I think most people learn that very much on their own, but oftentimes thinking about it in a little bit more organized fashion can be really helpful. So it's I think it's reasonable. So,
Thank you.
Yeah.
I have IBS, and I've heard that it could be related to my incontinence. Is that true?
I think if you're talking about fecal incontinence, that is definitely true. Some people with IBS struggle with either constipation or diarrhea, and extremes of both can be associated with accidental bowel leakage or fecal incontinence. And pelvic floor muscle exercises through a physical therapist can help with that, regardless of the stool consistency. Sometimes, too, just getting on a good bowel regimen through a combination of diet or laxatives can help you be more regular, which can make stool more predictable. We here at the University of Michigan have a program called the Michigan Bowel Control Program. It's a multidisciplinary clinic where we have urogynecologists like us, as well as gastroenterologists who are specialists in the intestinal system, and then also colorectal surgeons and physical medicine and rehabilitation doctors working together to solve these issues. And so I think depending on what kind of incontinence you're talking about, it could absolutely be related. And managing your IBS better, whether it be IBS with diarrhea or IBS with constipation, can really help impact how it impacts your life.
I think one thing that's probably worthwhile to talk about that is with IBS, if your symptoms are more constipation predominant, it's been long appreciated that, especially among younger children, if we can treat the constipation, that will often relieve the urgency and frequency and those type of problems. So I think more and more we certainly look at that and try to make sure that if somebody has a lot of urinary symptoms, especially urgency-related symptoms, I think we all certainly really focus on saying, that there's probably some contribution here of constipation to your overall symptom profile. So if we can help with that, it can often be a good fix that will help many things with discomfort as well as urinary symptoms.
And I think one thing that's counterintuitive to people about accidental bowel leakage and constipation is you think, oh, I'm constipated, why am I leaking stool? But extreme of constipation, getting very constipated, can actually result in fecal incontinence of liquid stool, which it can be confusing to interpret if you're thinking, oh, I'm constipated, what's going on? And I absolutely agree. Like people that are very constipated, that will aggravate overactive bladder type symptoms, and managing the constipation along with the overactive bladder is key.
Thank you. Is there a recommended time interval for timed voiding?
I think in general, we will start with trying to have you start in an interval where you feel comfortable. So for some people, that's going to be shorter than others. In general, I often tell my patients that if you can start at 1.5 or 2 hours, that's a nice place to start. But if it has to be a little bit sooner, then that's certainly reasonable. And I think so I would start at that. I would work in increments of 15 to 30 minutes. And now with the ubiquitous nature of cell phones and timers and other things, at least we have that. It used to be, I remember 10, 12 years ago, you'd say time voiding and say how, carrying a kitchen timer around. But at least now you can set yourself a little reminder with a cell phone that could fairly indiscreetly, help remind you that it's time to go.
I think too, when you're doing timed voiding, when you're working on that technique, working with pelvic floor muscle exercises or Kegel exercises in the context of physical therapy or not, you can also work on techniques like urge suppression, which maybe you start with your timed voiding and you're going every 1.5 hours, but as your pelvic floor muscle strength increases, as you're able to control those urges better, you can start to stretch it out. So it's not a commitment to every 1.5 hours I'm in the bathroom for the rest of my life. We're working from multiple levels, trying to stretch that out to get you to a point where your quality of life is maximized in the context of your bladder function.
And in general, if you're going fewer than 8 times a day, that has been recognized as something that is within the realm of normal. So there are people that go fewer than that on a day, but there's a range of people and a range of normal there. So certainly if you're going more than 8 times a day, that starts to get to the area where you start to think, is it fluid related? Or is this something that I'm just not able to hold enough? And that is something that we can help work through, as Dr. Fairchild was saying, with a combination of either sometimes physical therapy, medications, protocols around time voiding.
Okay. Excuse me. I was told I should wait until my baby is 3 to have surgery for prolapse because then I won't be lifting her so much. Do I need to avoid or minimize lifting post-surgery and post-recovery?
I think that's a really interesting question, and something that has been looked at in research studies is when we operate on people for prolapse or incontinence, what restrictions should we be giving people? And typically, I think it will vary institution to institution and among providers, even within an institution, about what we're going to tell people. I often go with 6 weeks of no heavy lifting. Some people say 4, some people say 12, which I understand for young parents can be very restricting if you have children, because you need to be able to pick them up. Even at 3, you might need to be able to pick them up. And they're not light typically at that point. When they've looked at studies in postoperative recovery and restriction of activities, they've not found that these strong restrictions of activities have made a difference. We still worry as providers that maybe we're going to affect something in the healing process, but the reality is we don't have evidence to support that. It's important. These are quality of life conditions, and the surgeries and treatments are meant to maximize your quality of life. And if what we're doing is impacting your quality of life negatively, it's not the right thing, is how I think about it. And so for my patients that have young children, I tell them to lift their children, maybe get somebody to help you. Maybe don't squat multiple times per day, but picking up the baby once or twice is not going to adversely affect your repair, is the bottom line, I don't think.
I think that's fair, and I think there's the other side of that question that is really interesting is what's the right time after having a delivery, and that's a complicated question. There's no one way you can answer it in a blanket way, but I think in general most of us really do try to do things to defer intervening surgically right after birth. In that there are sometimes things that have to be done, but in general, if you can delay that, I think we all recognize that there's so much recovery that happens that if we can step away and try to help support that person during the time to allow their body to recover, that in general they're going to be better off. So 3 years might be a little bit of a long time, but certainly we try to avoid doing something in the first several months.
And that's not only from that you may experience recovery on your own and not be as symptomatic as you were in the immediate postpartum period, but also, any woman that's had a baby, any woman that works with pregnant women knows the amazing change that the body goes through when you're having a baby. And that goes down to the blood vessels. They become very large, they're engorged, and so those changes are durable for the months after you have the baby, and we certainly don't want to be operating on people that have very large blood vessels and potentially higher risk for bleeding or complications after surgery because of that.
Thank you. Does it make sense to continue using a pessary post-surgery during times I expect to bear weight?
I can say that on a couple of occasions I have recommended that. I would say that they've been sometimes some situations where somebody's told me that they needed to have a repair for prolapse, which, if you think of it as a form of a hernia, you can imagine as we're trying to help those muscles and form scar and stay together. But let's say they're going to go back to a job where they're going to be lifting boxes of 40, 50 pounds on a regular basis, or they're going to be doing some type of other physical work that really is going to put a lot of stress on things. And at that point, I sometimes think that it's worthwhile. So that's a little bit of an extreme example, but I do think that there might be a role for it in certain cases. It's probably going to be different than the pessary that you had before surgery. And in general, we don't recommend it, but it's not, it's a reasonable question to ask. Just be something that you'd really want to take up with your provider.
I don't think there's a really right or wrong answer to that question.
It's a really interesting question, something we could potentially study.
I sometimes think of it as people wear back braces all the way around, so why not? Why not?
Why wouldn't we?
When assessing pelvic floor disorders, do you conduct a comprehensive review of medications that may be contraindicated?
So maybe could you repeat that? This one?
Sure.
Yeah.
When assessing pelvic floor disorders, or for a pelvic floor disorder, do you conduct a comprehensive review of medications that may be contraindicated?
I think the answer to that is yes. When we see anybody as a new patient, we take a very comprehensive history, do a very thorough exam. I've had a lot of patients tell me it's the most thorough pelvic exam they've ever had. And so part of that is certainly the medications that you're using. Medications don't play a huge role in prolapse. That's more of an anatomic problem. There are certainly some aspects of urinary and fecal incontinence that can be impacted by various medicines that you take, and that's going to be part of our evaluation. Anyone we operate on, we do a very thorough review of their medications, their allergies, their history, so that we can do the safest possible surgery for them.
And I think sometimes reviewing the medication list, we can identify for patients with urinary incontinence changes that they might be able to discuss with their primary care provider for their hypertension medications or other medications that could potentially improve their bladder function and not impact their high blood pressure or their other issues they're having.
Okay, so we're getting close to the end of our chat, so we're going to take one more question. I have read scary stories about mesh. How can I make sure I don't end up having some of those problems?
Mesh has become a big topic. We all talk about this very often throughout our week. And mesh is complicated. There's a lot of different things wrapped up into that topic. We started using mesh in urogynecology as a treatment for stress urinary incontinence, a sling that goes underneath the urethra to help with that problem. That surgery is very successful, and we still do it. It's considered the gold standard surgery by all of our national organizations. The data are very solid and positive on that surgery. I think what happened is that we tried to kind of extrapolate from that incontinence surgery to fixing bladders and other dropped organs in the pelvis with similar products. And that's where we got into some trouble and some complications. And it's kind of a complicated long-term topic about how that whole process started. But a lot of those products are now undergoing much more thorough research and review. There is a role for some use of mesh. Certainly that incontinence sling is still something we all do on a regular basis, and it's still a great surgery. There's some role for the use of mesh in prolapse surgery. There's an abdominal surgery that we do through the abdomen that's very effective. But here at Michigan Medicine, we've seen a lot of patients that have unfortunately had many serious complications from mesh. We've taken out a lot of mesh. All of us do that. We have a lot of experience with that. We can often make people at least 50% better with that surgery, but it can be not a universal outcome. We put some mesh in here, but on a very limited basis. So we're also all very talented at doing surgery, like Dr. Fairchild said earlier, called native tissue surgery. And that just means we use your own tissue and some stitching material to resupport the organs that way. So I guess the simple answer to that question is, obviously, we've talked about not all problems in the pelvic floor need surgery or have to have surgery, so there's all those other options. And even if you have to have surgery, you should always be seeking out a doctor who can do that surgery in multiple different ways. Ask them if they can do your surgery without mesh, and go through a complex discussion of that. You know, if the surgeon says, no, we have to use mesh, that's never the right answer. And you should seek out another doctor who can offer you different options. Talk about that thoroughly. Why do you need mesh? What are the complications of the mesh? Most mesh is permanent, but not all of it is, and so ask if the mesh will dissolve over time. There have been good studies coming out in the last year or two about mesh does not cause cancer and mesh does not cause autoimmune disorders like maybe rheumatoid arthritis. That's not a connection. But there's still a lot of really scary stuff out there. I agree with whoever asked this question. There's a lot of scary stuff out there. In the past year, we know there have been stories in the New York Times, on 60 Minutes. There's a documentary on Netflix. And all of those are not maybe the full picture. And so that's another great thing to come in and have a talk about your body and your problems, and maybe mesh isn't even on the table for you. And so don't be scared off about seeking medical attention because of what's out there about mesh.
I think that's great. You know, I think it comes down to really, like you said, having a discussion with your provider, having confidence in the person that's taking care of you, and having a frank discussion about the risks and benefits of mesh, because there are absolutely benefits in individual patients, and then there's alternatives, importantly. So if you're never going to get to a place where you think any type of mesh is good, then we have other treatments for you. So don't be afraid to come to the physician and get an assessment because you think we're going to insist that you get mesh, because that's not the case.
And I would say just in general that at Michigan Medicine, the use of meshes tends to be reserved for very specific indications. So
Absolutely.
either there's some type of, the type of prolapse that you have is really one that makes us concerned that you would benefit from it. And that most often is going to be a patient who has had prolapse surgeries in the past that have not worked, and that there's been a recurrent prolapse. So I think, know that these things should be reserved for some type of very specific problem. And I think as you're talking with your physician or your provider, make sure you feel comfortable that you understand what that indication is, and that it's not just, that's what we do. And I think if you get good answers to that, that should hopefully really reassure you that it's the right thing for you to do.
Yeah.
Great, thank you. Well, we are closing in on the end of our chat today, so Dr. Schimpf, Dr. Morgan, and Dr. Fairchild, thank you so much for sharing your time and expertise with us today. Michigan Medicine provides a broad range of urogynecology services at a number of locations, including Von Voigtlander Women's Clinic in Ann Arbor, our new West Ann Arbor Clinic at Parkland Plaza, the Northville Health Center, and our clinic at Mid-Michigan Health in Midland. Several of our team members are also on U of M's Healthy Healing After Delivery Clinic team, providing specialized care for mothers with challenges healing postpartum. You can learn more about our services at www.umwomenshealth.org/pelvic floor. We also have a wealth of online resources on a number of women's health topics. You can check them out at www.umwomenshealth.org/women's-health-resources. Thank you to our audience for spending part of your afternoon with us. We hope today's chat has been helpful. We have a brief survey we prepared to help us learn how we can make chats like today's more helpful to you, and to help us identify more topics you'd like to hear about. If you registered in advance, you'll receive an email with a link, or you can check the comments to this video and we'll have a link there for you to follow. Thank you and have a great afternoon.